he talked about saroglitazar, and there are a few anti-diabetic drugs also which are effective against MASLD. And to talk about SGLT1 inhibitors, we have Dr. Manav and its effect on NASLD.
Thank you, Kaushal. So I will talk about SGLT2 inhibitors. The data is so overwhelming that I'm only going to present meta-analysis and RCTs. That's what my talk is going to be limited to. I've been asked to talk about diabetic and non-diabetic MASLD and what effect the SGLT2 inhibitors have on either. Just an introductory slide. So we understand sodium glucose cotransporter 2 is expressed in kidneys, in brain, in heart, and in liver. There is a plethora of data of benefit of these drugs in each one of these organs. I will restrict this to liver and give you a brief data about the other organ systems. We know that it inhibits glucose absorption at the kidney level, and there is associated weight loss, but that's not the only way it helps a liver patient with MASLD. At the liver level, it has multiple effects at cellular level. It enhances PPAR alpha and SIRT1. In that way, it stimulates lipolysis and fatty acid oxidation in these patients, hence mobilizes fat from the liver. Also inhibits SREBP1 and FAS, and hence lipogenesis is inhibited. So this was the first meta-analysis published in 2021. This is just the first one of the multiple ones, and there are at least 10, 12 after this. But what I'm going to discuss is the one which is the most recent and which has the most robust data. This was published last year in Nature Sciences report. 854 records were screened, and 18 randomized controlled trials were included in this meta-analysis. 16 of these 18 were in diabetic population. 2 of these were in non-diabetic population. Different trials measured the liver stiffness and fat quantification by different measures. So there were 6 studies, 6 randomized controlled trials, which did CAP scores to look at the fat quantification. Look at the forest plot. Now this diamond, which is a conclusion diamond, if it lies on the one side of the middle line, it means the effect of the drug under question is significant. So with a z-score of 2.71, the results are definitely in favor of SGLT2 inhibitors in patients who are diabetic and who are having MASLD. This is as per CAP score. 5 trials did MR-PDFF. Now MR-PDFF is probably the most sensitive and the best method to quantify liver fat. All these 5, except 1, 4 of them showed benefit in there was improvement in MR-PDFF fat levels in the patients who were on SGLT2 inhibitors. Mind you, these are all diabetic patients who were on SGLT2 for diabetes. And again, the diamond lies on the left of the middle line, which tells you that the quantification has significantly improved, the fat has significantly improved in the liver. Z-score here again is 2.01, that means more than 2 standard deviation difference. 7 trials assessed the fibrosis by measuring liver stiffness. If you look at all this data, again the diamond lies on the left side. Z-score 2.58. One of these trials, the Taheri trial in 2020, actually was in non-diabetic population. So if you take out that trial and take the other 6, the data is more overwhelming. Z-scores 3.97. So significant improvement in LSM in patients, diabetic patients who have MASLD. FIB4, similar results. More than 9 trials, I think 10 trials here, which actually measured FIB4, and FIB4 improved significantly in the patients who were on SGLT2 inhibitors. There were 2 trials which looked at histopathology, only of these 18 which we talked about. Both were again in diabetic population with MASLD. You look at hepatocyte ballooning, there is more than 1 score reduction in SGLT2 as compared to those who were not given SGLT2. And there was more than or equal to 1 stage reduction in fibrosis in the patients who underwent biopsies in these. So there is data to suggest that SGLT2 inhibitors are very useful in patients who have diabetes and have MASLD. But I think this is one study which we must go back and read. This is a population-based study. Now this is a Korean population-based study, and you look at the inclusion, almost 10 lakh patients. These are all patients who had fatty liver index more than 60. So fatty liver index is again a non-invasive test, NIT, which Koreans use to diagnose fatty liver. Any value more than 60 is considered a fatty liver patient. Of this, all those patients who were recently detected diabetic from 2014 to 2018 and started on one of the 4 anti-diabetics which we talk about, which we commonly use, were included. That is 80,000 patients, of which 10,000 were on SGLT2 inhibitors, some on thiazolidinediones, some on DPP4 inhibitors, and some on sulfonylureas. Look at the MASLD regression. The orange line is the patients who got SGLT2 inhibitors. Significantly better as compared to all other 3 classes of drugs. Better than sulfonylureas, better than DPP4 inhibitors. Mind you, we did not include GLP-1 here because GLP-1 is supposed to have other effects also. This trial did not talk about GLP-1 here. Look at liver-related outcomes. The best liver-related outcomes were seen in the patients who were on SGLT2 inhibitors. So this is reasonably conclusive data to tell you when you use SGLT2 inhibitors for diabetes patients, it helps MASLD, it decreases fat, it improves fibrosis, and it helps in decreasing liver-related outcomes. What about non-diabetic population? There are 2 randomized controlled trials. I'll briefly discuss both of them. How much time do I have? 2 minutes, okay. So the first trial was published from Iran. 43 versus 47 patients, empagliflozin versus placebo. It was given for 24 weeks. And they used transient elastography to assess fat and fibrosis. What they did show was a significant improvement in AST, ALT, fasting serum insulin levels, weight, BMI, and waist circumference. However, both in empagliflozin and in placebo, there was significant reduction in CAP score. Please remember that all these patients were given weight loss reduction advice, dietary advice. So even in the placebo arm, there was significant reduction in CAP score. But when they did a subgroup analysis, which was not the part of the initial primary endpoint, what they realized was if the CAP value was more than 302, the fat did decrease in the group, even in the placebo group, but the quantity of fat reduction, the degree of fat reduction was more in the patients who were in empagliflozin. That was 37% versus 17%. Relative fat reduction. Although the 17% fat reduction was there in the placebo arm also. They did not document any improvement in LSM in this group of patients. Second RCT, dapagliflozin versus tenecliptin. Again, they looked at ALT, body weight, and body composition. ALT decreased, body weight decreased, but there was no improvement there was no difference in fat improvement in both the groups. It was similar. Just 2 slides about other benefits of SGLT2 inhibitors. Now, this is a meta-analysis again. 11 randomized controlled trials, 34,000 patients. These are diabetic and non-diabetic population. They are looking at cardiovascular, major adverse cardiovascular events. 25% of these patients were non-diabetics. They had 4 categories. Major adverse cardiovascular events after MI, major adverse cardiovascular events without MI, in patients who had CAD, in patients who did not have CAD. And you see the diamond lies on left side in each one of these categories. Whether the patient has CAD or does not have CAD, if they are getting SGLT2 inhibitors for their diabetes, the major adverse cardiovascular events are less. Similar data in patients who have CKD or they don't have CKD. This is again 12 RCTs, 90,000 patients. 40,000 of these 90,000 had a CKD, proven CKD with a eGFR less than 60. Other 50,000 had a eGFR more than 60. And cumulative CKD progression or patients developing CKD in this group was better in patients who were getting SGLT2 inhibitors. So my dear friends, to summarize, SGLT2 inhibitors improve hepatic steatosis and fibrosis in patients with MASLD and type 2 diabetes. SGLT2 inhibitors have a favorable influence on MASLD progression as well as liver-related outcomes compared to other diabetic drugs. Evidence of its effect in a non-diabetic MASLD population is sketchy as of now, but I guess more data will come. We might be using these drugs even in patients who have impaired glucose tolerance in time to come. As of now, we don't have enough evidence for that. However, even in non-diabetic population, it does prevent major cardiovascular and renal-related events. Thank you for your patience listening. I'll be happy to take any questions. What I've not done is, what I've not talked about is which category of patients we cannot use them. You should go back and read about that. There are some category of patients where they cannot be used. We should be aware. Because of 8 minutes time, I desisted from talking about that. Please.
Manav, literature mentions about it, effect on extrahepatic cancers, reduction of esophageal varices, extrahepatic cancers.
Extrahepatic?
Including, there is one Korean study mentioning about effect on SCC reduction.
So I see, lack of time, I did not cover that. There is some data to suggest that it may decrease HCC incidence, but again, data is less, I believe.
Manav, is it, this side, Manav, is it fair to say that SGLT2 inhibitors would be our first choice in diabetics with MASLD?
I firmly believe that, sir. Dr. Sania will support me here. SGLT2 inhibitors should be the first choice antidiabetics in antidiabetic medication in patients who have type 2 diabetes, whether or not they have type 2 diabetes. Sorry, whether or not they have MASLD. I guess the endocrinology people are also moving to SGLT2 inhibitors over any other antidiabetic medication. Sir.
Dr. Manav, I agree that SGLT2 inhibitors are a very good group of drugs. So one of the major problem is urinary tract infection, especially in patients with BPH. So how do you go about it? When we usually do the urine routine after a couple of weeks and then monthly, we find that many of these patients have bacteria, but they aren't asymptomatic. So would you, what is your plan as regards urinary tract infection?
Sir, for asymptomatic bacteriuria, I don't pay much attention to. Anybody who has recurrent UTIs on SGLT2, it is a contraindication. The other problems are some of the male patients may develop balanitis. That also may becomes a contraindication. The penile infections, that also happens in these patients. You have to be very careful using these patients. Patients who already have cirrhosis, you have to be very careful. Patients who are on diuretics, you should not be using SGLT2 because they can cause dehydration, they can cause AKIs. So there are multiple contraindications. I would suggest that you go back and read which category of patients you cannot use them. Otherwise, these are very good drugs to use.
Manav here, Charles here. Hi.
Yeah.
So if you look at all the studies of SGLT2 inhibitors, you see that there's a significant reduction in the HbA1c. So is the improvement in MASH effect of better diabetic control or the direct effect of the drug on the liver?
So it does act on the liver itself in addition to diabetes control. So there are SGLT2 receptors expressed in hepatocytes also. So for me, it's very difficult to answer that question because I don't do animal studies, I don't have basic research data. But the pathogenesis of NAFLD and the expression of SGLT2, sir, you want to answer that, sir, please. Dr. Sania is the right person to answer that, please.
So what happens is when you give a SGLT2 inhibitor, the primary mechanism is in the kidney, so you're losing glucose. So when you lose glucose, you force the muscles to start burning fat as their primary source of energy. And one of the fundamental defects in insulin resistance is that your muscle forgets when to switch in the postprandial state from where you're primarily burning glucose to the fasted state where you're normally supposed to be burning fat. So it is unable to burn the fat. So when it cannot burn glucose, it uses up protein for energy. So you get sarcopenia. So what this does is by forcing the glucose out of the system, it pushes the metabolic machinery to go back to burning fat. So by doing that, you improve insulin sensitivity. And by doing that, you reduce the amount of fatty acid that is going into the liver to be, to move towards fatty liver. Because now you're burning the fat in the muscle. Right. And the glucose is going out in the urine. So the two sources of fat, one is glucose for de novo lipogenesis, and the fatty acid from the adipose tissue, both are decreasing. So you're turning off the fuel to the fire in the liver. Because the metabolic substrate is the fuel, right? Oxygen. So you're turning off the oxygen to the liver fire. And so the liver tends to cool down. So that's sort of the mechanism.
Thank you, sir.
Excuse me, one comment and question also to the panel, please. Sir, I am Dr. Like I mentioned, practicing as physician and lot of interest in the bariatric medicines. So what I have listened from all the learned speakers about retatrutide. Another molecule which is in trial is survodutide. Dr. Sanyal must be including their patient for trials. What they found, it is the glucagon level which is working on the liver fat cells and reducing effectively. So in fact, glucagon is not an omen. It is rather helping and working in a glucose-dependent manner, maximum at the liver level. Even SGLT2, it increases the glucagon levels. So I think it may not be working in the subgroup of patients where we may be adding something like DPP4 inhibitors, which is usually included along with that, which counters the glucagon effect of the SGLT2 inhibitors. So my comment, question, and may not be this, all the molecules may be working because increasing glucagon levels in the fat cells, because the survodutide is the one thing which is focusing only on the glucagon. Otherwise, it would have increased the sugar levels. So please comment from the panel.
So I am not able to get the question correctly. I'm sorry.
There's
some echo here. So.
Yeah, I'm just saying it is the glucagon levels which are increasing all the molecules, whether retatrutide, survodutide, SGLT2 inhibitors, all the molecules. And the glucagon has maximum effect on the liver in reducing the fat.
So glucagon is a double-edged sword, because on one hand, a little bit of glucagon will improve fat oxidation and mitochondrial biology, so it will reduce oxidative stress. But if you get too much glucagon, then you are making too much sugar, you're increasing hyperglycemia, and you're actually promoting tissue breakdown. So glucagon is there's a narrow window where you have to optimize the glucagon. So it's not glucagon alone or insulin alone, it's really the ratio of insulin glucagon through the fasting and the postprandial state. And you're absolutely correct, the glucagon targeting adds to the GLP benefits, because GLP has no receptors in the liver, and the glucagon directly targets mitochondria and some other pathways in the liver.